Hello everyone, welcome to the online module of Kerala Neonatal 2023. From in this session, we'll be discussing regarding the blood gas analysis in NICU. The main objectives of this session are the indications for blood gas analysis, the pre-test considerations, sample collection for blood gas analysis, the blood gas parameters, and interpretation of the same. So the indications include a sick infant, if there is respiratory or metabolic disorders like inborn errors, respiratory failure, hypoxia, hypercarbia, suspecting or the patient is in shock and for monitoring, then sepsis, and decreased cardiac output states and renal failure conditions. The pre-test considerations include the sample site from where we are going to take the sample, then status of the patient, whether the patient is ventilated, is having shock, or having metabolic acidosis, hypoxemia, then the technique of blood sampling, whether it is from which side and how we are taking, whether it's in the syringe or in the capillary, then the storage time. These are the main pre-test considerations. So we'll see how the sample collection goes. Like if we are taking the sample from indwelling catheter, the indwelling catheter can be in the umbilical artery or in the peripheral artery. So if you are planning to put a peripheral arterial line or planning to prick a peripheral artery, we have to make sure that the distal limb is properly or sufficiently getting blood supply through another route. So Allen test should be performed in the hand. And if you are taking the syringe should be rinsed with haploheparin or a lower concentration of heparin, because the heparin itself is an acid. So if an increased quantity of heparin can cause acidosis. And if you are taking from the umbilical arterial line or the arterial catheters, we have to take 3 to 4 times the dead space volume in a separate syringe and keep it aside, and then take the sample for testing, and we have to give back the initial volume that we have taken to the baby, and that should be given very slowly because that will prevent more blood loss from the infant. And if we are planning to take from capillary, we have to avoid the posterior portion of the foot, and we can prick on the medial or the lateral aspect. And another major thing that we have to do for a capillary blood gas is pre-warming the area. So warming will cause dilatation of the capillaries, and thus they will become arterialized. So from that, an arterialized capillary, the blood is flowing from the artery to the capillary directly, and hence the blood that is flowing in the capillaries will be similar to that in the artery. Hence, we can get a near arterial blood gas reports from a capillary sample, and we have to avoid squeezing the area for taking the sample, and we have to avoid the first drop. And we should be making sure that there are no air bubbles in the sample, because if air bubbles are there, the PO2 can reach near the atmospheric levels or 150 millimeter of mercury, and PaCO2 will fall to nearly 10, because the PaCO2 level in the atmospheric air is very negligible. And next thing is about glass syringe or plastic syringe. In plastic syringes, there can be diffusion of air into the sample. So especially if the sample is analyzed after a while, or if there is a long gap, then it's always better to take in glass syringe, because glass won't allow the diffusion of air into the sample. And we have to homogenize the sample by keeping it in between the palms and rolling it horizontally. Especially in case of capillaries, it's more important because we are testing with very little amount of blood. And we have to test at the earliest, because for every 10 minutes, if the sample is kept at 37 degrees Celsius, the pH will change by 0.01 and PaO2 will change by 0.1 millimeter of mercury, and PaCO2 will also change by the same amount. But if it is kept at 4 degrees Celsius, the change will be 1/10 of it. So we have to keep the sample in ice pack if it is not loaded to the machine at the earliest. Next is venous versus arterial. Nowadays, venous gases are being done more than the arterial gases, because with an adequate venous sample and with the proper pulse oximeter, we can have proper monitoring of an infant in the ventilator on if the baby is on ventilator. So the acidic, the pH in the venous blood gas will be more acidic than that in the arterial, and so the pH will decrease by 0.03, and PaCO2 will be on the higher side in the venous as it is expected, and it will be around 5 to 6 millimeter of mercury. And bicarbonate, if we take the standardized bicarbonate, it will be the same. And the venous sample is not at all reliable for oxygen pure. The capillary blood gas, we have to get that through arterialization of the capillary. There is increased chance for exposure to atmosphere and erroneous values. Hence, the proper expertise in collection as well as loading the sample should be there, and it is more reliable than a venous sample, especially for the PO2 and pH, PCO2 and bicarbonate also. So the parameters in a blood gas report which we are more concerned are, one is pH, and pH which can be temperature corrected, PaCO2 which is again temperature corrected, PO2 which is again temperature corrected, because temperature correction is important in blood gas analysis, because we have to know that we have to know what is Henry's law. According to the Henry's law, the solubility of air of a gas is decreasing with increase in temperature. And another thing that we have to be taking care of is, if solubility is decreased, that will lead to increased partial pressures, because more air will be turning from the dissolved form to the gaseous form. So the partial pressure will be increased if the solubility is decreased. So we have to take consideration of the carbon dioxide. Okay. So with increase in temperature, there will be decrease in solubility of the carbon dioxide. There will be increase in carbon dioxide. So the increase in, and the decrease in temperature. Maybe decreased and pH will be increased. Okay, when it's measured lower temperature or at the same temperature. So the main concern, or why we are doing temperature correction, is the sample is pre-warmed to 37 degrees Celsius for measurement in the blood gas analyzer. So if we have taken the sample at 34 degrees Celsius, which is the temperature of the patient, and if we are analyzing that by making the temperature increase up to 37 degrees Celsius, errors are going to happen. Hence, it should be corrected for the temperature. So even if the machine measures the levels at 37 degrees Celsius, it will correct the values for the patient's temperature. So there is an option to input the patient temperature in the blood gas analyzer. So this is a sample blood gas report. Here the patient's name, ID will be written, and the sample type, this was a venous sample, so it is venous, and the temperature of the patient, it is 37 degrees Celsius. So the 37 degrees Celsius is the patient temperature, and that is the temperature at which the machine is measuring the blood gases or the pH acid-base balances. So here, these are the measured values through the electrodes. And here comes the temperature corrected values. So as the patient's temperature is 37 degrees Celsius, the temperature corrected values and the blood gas values are the same. Okay. So next is bicarbonate levels. So bicarbonate level is a calculated value, and this it is calculated from the carbon dioxide at 37 degrees Celsius, and pH and carbon dioxide are playing a major role in that, and it is measured at 37 degrees Celsius. So the standard bicarbonate is independent of carbon dioxide because it is measured at a partial pressure of 40 millimeter of mercury for the carbon dioxide. So standard bicarbonate is independent of carbon dioxide, and that is what the measurement that we are looking for. So this is the one standard bicarbonate, which is the one that we have to look in the blood gas analysis. And the next one is base excess. Base excess we can get for the whole blood as well as for the extracellular fluid. So the extracellular fluid base excess is independent of the partial pressure of carbon dioxide. Hence, the base excess ECF or standardized base excess is the one which is being taken for clinical purposes. So there will be affix of C for all those calculated values. And in this blood gas machine, we can see that it's measuring the methemoglobin levels, fetal hemoglobin, oxygen saturation, hemoglobin levels, bilirubin, lactate, and glucose. And some can have electrolyte values also. Some will be calculated values, and others can be directly measured also. And we can write the patient's status, which or what is the respiratory support the patient is having at the time of the sampling, blood sampling. So the parameters to consider are pH. So if it is less than 7.35, it is acidosis, and more than 7.45 is alkalosis. Then PCO2, more than 50 is hypercapnia, and less than 35 is hypocapnia. Then oxygen, normal is 50 to 70, hence hypoxia is less than 50 and hyperoxia is more than 50. And bicarbonate normal levels are 20 to 24, and base excess it can be from -5 to +5. So now we will analyze blood gas samples. So the stepwise process include, first is whether the pH is acidosis, showing acidosis or alkalosis. And the next is the primary cause of the disturbance. And third is it a compensated one? So it will be shown by the pH and the equations to assess the compensation. And is the compensation is adequate or not, or appropriate or not? And fifth, we'll go with the management of the patient. So if the pH is less than 7.4, it is considered as acidosis. Next, we will look at the bicarbonate. So if the bicarbonate is on the lower side with acidosis, that means there is metabolic acidosis. So we have the compensation comes from the respiratory arm in these cases. So this is the primary cause. And then for compensation, bicarbonate and carbon dioxide should move in the same directions. So for 1 milliequivalent per liter decrease in bicarbonate for a metabolic acidosis, carbon dioxide should also decrease. That will be by 1.2 millimeters of mercury. Okay. So for each 1 milliequivalent, 1.2 millimeter of mercury decrease in the partial pressure of carbon dioxide. In case of respiratory acidosis, where PCO2 is increased, there will be increase in the bicarbonate levels, okay, or the base levels to compensate for the acidosis. So in acute cases, the kidneys are little bit lagging for the compensation. So in the acute phases, there will be 1 milliequivalent per liter per 10 millimeter of mercury of carbon dioxide rise. But in chronic cases, kidneys would have already adjusted to that and will show an increased response with 3.5 milliequivalents per liter of bicarbonate increase with each 10 millimeter of mercury increase in the PCO2 levels. And if it is alkalosis, the pH is more than 7.4, we have to again look at the bicarbonate and the CO2 levels. And if the bicarbonate is increased, that is towards the metabolic alkalosis side. And for each 1 milliequivalent increase in the bicarbonate levels, there will be an increase of carbon dioxide by 0.7 millimeter of mercury. And in respiratory alkalosis, for every 10 millimeter of mercury of carbon dioxide decrease, there will be 5 milliequivalent per liter of bicarbonate decreasing as a compensatory measure. So we can see that kidneys have to conserve bicarbonate in case of respiratory acidosis, and will have to lose bicarbonate in case of respiratory alkalosis. For respiratory alkalosis compensation, they are able to lose 5 milliequivalent. It will be on the 5 milliequivalent of bicarbonate per 10 millimeter of mercury loss in carbon dioxide, whereas in acidosis conditions, in acute situations, it will be 1 milliequivalent per liter, and in chronic conditions, it will be 3.5 milliequivalent per liter of bicarbonate, which is getting conserved per 10 millimeter of mercury increase in the carbon dioxide levels. And there are two equations that you have to remember. There are so many equations that can be used for calculating the compensation, but you have to remember at least one or two. Only those you have to remember. Otherwise, if you remember all of them, you will tend to forget it. So you can go with these two equations. So the partial pressure of carbon dioxide will be 1.5 times bicarbonate plus 8 plus or minus 2 in case of metabolic acidosis, and 0.9 into bicarbonate plus 16 in metabolic alkalosis. It can be plus or minus 5 also. Now we'll analyze some of the blood gases. Okay, so in this blood gas, the pH is 7.29. So that is acidic. PaCO2 is 58. It is again acidic. And bicarbonate is 23. That is, bicarbonate is just on the upper side. It is not acidic, and it is for the alkaloid. So here what happens is the pH is acidic and PaCO2 is moving in the acid direction, or it is increasing. So this is a respiratory acidosis. And there is a drive from the kidney side to increase the bicarbonate, but still the pH is not normal. So it is an uncompensated respiratory acidosis. And there is a slight compensation occurring. So we can measure the compensation that has happened, because if it is an acute respiratory acidosis, so for acute respiratory acidosis, for each 10 millimeter of mercury change in PCO2, there will be 1 milliequivalent per liter decrease in bicarbonate. Sorry, increase in bicarbonate. So here, if we keep 45 as the normal, there is increase by 13. So the bicarbonate should increase by 1.3. So it is increasing from 22 to 23. Okay, but it is not fully compensated. And here in the next blood gas, you can see that it is acidic gas, and there is PaCO2 which is on the normal side or decreased, and bicarbonate is decreased. So it is a metabolic acidosis. And in this metabolic acidosis, there should be respiratory compensation. So for metabolic acidosis, for each 1 milliequivalent per liter decrease in bicarbonate, so here there is a decrease of 7 from 22. There should be a decrease of 1.2 millimeter of mercury in carbon dioxide. So this should be 7 into 1.2, 8.4. So if we consider 40, it is around 35. So there is compensation happening in the respiratory component, but it is not completely compensated, and hence the pH is on the acidic side. In this blood gas, again, we can see that there is alkalosis because the blood pH is more than 7.5 with a low PaCO2 and a somewhat lower bicarbonate also. So bicarbonate, if it is decreased, that will cause acidosis, but the pH is on the alkalotic range and there is PaCO2 which is decreased. So the primary cause is respiratory alkalosis and there is a compensation happening. And in respiratory alkalosis, what is the compensation? So for each 10 millimeter of mercury decrease, there will be 5 milliequivalents per liter of bicarbonate which will be decreased. So here there is a decrease by 50 milliequivalents in PaCO2. That will correspond to a decrease of 7.5 in bicarbonate. So here bicarbonate is decreased by 4. So that's why there is uncompensated metabolic alkalosis. It is not completely compensated. Okay. In this blood gas, again there is alkalosis, but PaCO2 is normal or just increasing and bicarbonate is also increased. So this is a metabolic alkalosis. Okay, and there is increase in the carbon dioxide levels also. For in metabolic alkalosis, how is the correction going? For metabolic alkalosis, each 1 milliequivalent per liter increase in bicarbonate, there will be 0.7 millimeters of mercury increase in PaCO2. So here it's increased by 7. So this should carbon dioxide should increase by 7 into 0.7, 4.9 or nearly 5. So carbon dioxide is increasing, but it is not increased up to the complete compensation levels. And still there is metabolic alkalosis in this part. Now we'll see another blood gas. Okay, here this is a patient who is on ventilator and is having blood gas at 10 p.m. The gas is showing a pH of 7.2, PaCO2 of 62, and a bicarbonate of 18. So it is acidic pH, PaCO2 is increased and bicarbonate is decreased. So this comes as a mixed acidosis. But we have to know whether this mixed acidosis is caused or is the major defect in this infant. So for that, we need to know the previous blood gases. So if we look at the previous blood gas, we can see that at 6 p.m., the same infant had a perfect gas with the PaCO2 of 42 and bicarbonate of 20 and a pH of 7.35. But at 10 p.m., this guy has got respiratory acidosis with increase in the PaCO2 levels. And the bicarbonate is not that much decreased. Okay. And that is mostly because of a tube block or a developing pneumothorax. So with tube block, there was respiratory acidosis, and it got corrected with suctioning, proper suctioning. So what happened is the blood gas became normalized. Okay, and basic the bicarbonate levels also improved. Okay, so here there is respiratory acidosis, which has played a major role in the acid-base imbalance. So we have to correct the carbon dioxide levels or the respiratory acidosis through the ventilator adjustments and the suctioning, and then we will be reaching to a normal or near normal blood gas levels for the infant. So it's not a single blood gas that can tell you about the patient as a whole, but you will have to see the serial blood gases. This is another patient. Here, there are two blood gases on 2 different days. So we can see that the pH is almost the same. PCO2 is almost the same. pH has actually increased by 0.05. And the reason was the bicarbonate. Bicarbonate has increased. So we have to know why bicarbonate has increased. Is it because of some causes like NG tube aspiration or vomiting, which caused a chloride washout and carbon dioxide bicarbonate increase? So for that, we need to know the clinical background of the infant. So to assess or identify the changes in the blood gas, you have to know the clinical features, a clinical background of the patient and the status of the patient. This was a patient who had bronchopulmonary dysplasia or chronic lung disease and had a BPD spell and was treated with diuretics at that time. Okay, so the diuretics will cause metabolic alkalosis. Most of the diuretics will cause metabolic alkalosis. So that is the reason why bicarbonate was increased. So you don't need to do anything for this apart from just waiting to get this normalized and stopping the bicarbonate, stopping the diuretic if it is not required. And this is another blood gas in which you can see that the serial monitoring, there was almost a good blood gas, and there is a decrease in the pH here to 7.25. So that has become acidic. And if you see this single blood gas, you will find that if you are looking at the single blood gas of these, you will find that there is respiratory acidosis and there is metabolic acidosis. So this is a mixed disorder. But if we look at the serial blood gases, we can tell that the metabolic acidosis is improving and there is a worsening in the respiratory acidosis. If this patient is on ventilator, we have to look for the tube block or pneumothorax or other reasons for the carbon dioxide retention, like a minimal tidal volume, decrease in the tidal volume or the minute volume. So now, after discussing the blood gas analysis, we'll see what are the reasons or causes for metabolic derangements and how we will treat it. Metabolic acidosis can happen with poor perfusion and anaerobic metabolism, which will cause increase in the lactate. The conditions like hypothermia and hypoxemia will lead to anaerobic metabolism and poor perfusion. And then PDA, decreased cardiac output, sepsis, imbalances of metabolism, where you can get increase in organic acids and increased protein load, and then renal wasting of bicarbonate, especially in preterm babies who are having immature kidneys. And for metabolic acidosis, we can make use of anion gap to identify the reasons. So usually elevated anion gap will be there in case of acids like lactate, keto acids, then sulfates, phosphates, and inborn errors where you can get the organic acids. So the anion gap will be elevated, and a normal anion gap metabolic acidosis can happen in bicarbonate losses, direct loss of bicarbonate, and it can happen with renal or GI losses or hyponatremia with the ECF dilution. So to treat metabolic acidosis, the major thing is the supportive care of the infant and treat the cause, treat the cause. Then the patient will need fluid boluses and inotropes in case of poor perfusion, especially if the pH is less than 7.2. And there is one therapy that is discussed in majority of the NICUs and currently which is becoming obsolete, that is bicarbonate therapy for metabolic acidosis. So bicarbonate therapy is indicated if there is excessive loss of bicarbonate through the renal wasting. But for metabolic acidosis, because of decreased perfusion or hypothermia or shock, bicarbonate therapy is not the first option. You have to give fluid bolus and you have to give inotropes, and if still the acidosis is not improving and the pH is going below 7.1 and bicarb is going less than 6, that is the time when you can give bicarbonate. So the patient should be on inotropes and the pH should be less than 7.1 and bicarbonate is less than 6. This data is from adults because such kinds of studies are not done in there in the neonates as of now, and we have got these data from the adults. And you can give bicarbonate only if there is adequate alveolar ventilation is happening. Okay, and the dosages, there are different dosages for bicarbonate in different centers. Some centers will give 2 ml per kg of sodium bicarbonate solution over 6 hours, and some centers will give an old complete or half correction doses with the equation considering 18 as the basal level. So but as of now, the bicarbonate therapy has got more risk factors for poor neurological as well as poor outcome in terms of intraventricular hemorrhage and increased chance of intraventricular hemorrhage and mortality, increase in mortality. Hence, bicarbonate therapy is not routinely used for the resuscitation cases, for neonatal resuscitation and for neonatal shock, unless there is worsening or not improving the metabolic acidosis with inotropes and fluid boluses. Next is respiratory acidosis, which can be there because of atelectasis, BPD, pulmonary hypoplasia, in mechanical ventilation, if there is block or inadequate minute ventilation, there is muscle weakness or directly with the muscle or neurological and structural lung or musculoskeletal issues. So the effects of respiratory acidosis are increase in carbon dioxide will cause impairment in the cerebral autoregulation, and it can also cause increase in the pulmonary vascular resistance and will worsen oxygenation in hypoxic respiratory failure as well as in PPHN. So respiratory acidosis can have worse a worsening effect in the hypoxic respiratory failure by increasing the pulmonary vascular resistance by acidosis. And how to treat it? So if the patient is on non-invasive ventilation and is developing severe or significant respiratory acidosis with a pH of less than 7.25, you might have to take the baby onto the ventilator, or if the sometimes you can even try with increasing the flow, but not to be given very high flows. Usually the flows will be around 8 liters per minute, and more than that is not recommended. And ventilators, you can increase the PIP and you can increase the rates, respiratory rates, or you can change the modes from IMV or assist control to PTV or SIMV mode to decrease or help the patient to improve the minute ventilation. And if the baby is on SIMV and on high settings with a persistent or worsening hypercarbia, you might have to go for high frequency oscillatory ventilation. Then combined respiratory and metabolic acidosis can happen with HIE and BPD with acute metabolic acidotic conditions. These are the major two conditions in which you can get a mixed acidosis. Then respiratory alkalosis can happen with hyperventilation or inadvertent high tidal volume in mechanical ventilation, and patients with HIE who are having hyperventilation in the hyperventilation phase, not in the initial phase. And the effects are, it will cause pulmonary vasodilatation and cerebral vasoconstriction. So the cerebral vasoconstriction has got poor effects in the neurological outcome. So it can lead to PBL, and also it can, especially in the preterms, and poor outcome in HIE in term babies. So we have to prevent respiratory alkalosis for a good neurological outcome. So it can be mainly iatrogenic. So we will have to adjust the PEEP and the rate, and if the patient is on HFO, the delta P should be adjusted, and we have to prevent HIE, which are the major cause of respiratory alkalosis. Then metabolic alkalosis, usually it is caused by loss of chloride through diuretics, then vomiting or secreted diarrhea. Then in case of Bartter syndrome, or if there is alkali infusion or hypokalemia, in these cases metabolic alkalosis can happen. And the next is apart from PCO2, pH, and bicarbonate, we have partial pressure of oxygen also in the blood gas, especially if we are taking the arterial gas or the capillary gas. So it can detect hypoxemia. So hyperventilation may be the major cause for hypoxemia, especially if there is a poor drive or mechanical reasons like structural abnormalities of the lung, like the CDH, which will cause congenital diaphragmatic hernia, which will cause hypoventilation by decreasing the tidal volume. And if there is ventilation perfusion mismatch, especially in conditions like RDS or right-left shunts and methemoglobinemia, will all cause hypoxemia. So in hypoxemia, one major index we have to which will help in the prognostication. So that is known as oxygenation index. So oxygenation index is the mean airway pressure into FiO2 into 100 divided by the post-ductal PO2. So if a map of 10, so oxygenation is a map of 10 with an FiO2 of 50% and into 100 divided by the PO2 of 100. So the oxygenation index is 5. So it's a good oxygenation index actually, because if it is going above 15, that is the time for INO in case of PPHN. And if it goes to 20 to 40, the mortality risk is around 50 to 60%. And if it goes beyond 40, the mortality risk is 80 to 90%. And it is the time to consider ECMO if indicated. So these were the major blood gas anomalies that we discussed: metabolic acidosis, metabolic alkalosis, respiratory acidosis, and respiratory alkalosis, and how to look for the acid-base status. First, we have to look for the pH. Then we have to look for the primary cause for the metabolic disturbance, whether it's a metabolic one or is it a respiratory one. And then how is the compensation going, and how much compensation has occurred, and whether it's a completely compensated or uncompensated condition, and is there a mixed disorder, And the major things that you have to always remember are a single blood gas is not going to tell you regarding the patient's condition unless you know the status of the patient or the previous blood gases. So serial blood gases are important to know the exact status of the patient, and patient's status is absolutely required for a proper management with the help of the blood gas. Thank you.